I've talked to centers that refuse the dollars, and they say that they won't be allowed to pray with their patients or share the gospel. Is that true?
Not when you're talking about Medicaid, Medicare, or private insurance. Absolutely not.
Some people say you should be sharing the gospel in every single interaction. If they see 40 clients, all 40 of them, they're sharing the gospel. What do you think about that?
I have a problem with that. He had matched for a heart 4 times before that, but they had turned him down because there was no aftercare, no adoptive family. And the only thing she asked us was, when he dies, will you invite us to the funeral? The adoption was finalized on December 21st, 2021. It is our understanding that he is the only unvaccinated pre and post live organ transplant child in the nation.
If your stereotypical pregnancy center was to be audited or attacked or investigated tomorrow, what would be the most likely thing that they would not be ready for? Welcome to Pro-Life Unfiltered, where we host bold conversations for those building the movement. So our guest today is Shawn Zierke. She's a consultant many leaders describe as the Swiss Army knife of solutions and knowledge for pro-life medical nonprofits. She works at the intersection of governance, medical clinic operations, AAA-HC accreditation, grant writing, AI implementation, and strategic growth, helping organizations move from good intentions to real excellence. Shawn, welcome.
Thank you. How you doing, Benjamin?
Doing pretty good. That was a mouthful. You are all over the place. I know what you mean now by Swiss Army knife. It's right there in
That's
your
right. It's the
in your
best way to
bio.
describe me.
Well, it's good. Um, you know, some people may or may not know, but you've done a bit of consulting for us too, and you've dabbled in a lot of different areas. So you're just always learning new things that you do, and it's been pretty helpful for us. But now I know since then, you also have a ton of other pro-life orgs, mainly pregnancy medical clinics, right?
Yes. Yep. I would say I'm that and state coalitions. So because of my MBA in social entrepreneurship, which is the business of nonprofits, all the benefits of whether you're a 501c3, C4, C6, I have made it my work to and purpose to be an expert in. And then the most effective, in my opinion, pregnancy health organizations are pregnancy medical clinics because they're meeting women where they're at in the moment of crisis with the medical care that they need.
So I want to dig into that because it's definitely your forte in your area of expertise, and you know more about that topic than probably anyone else that I know. But before I dive into that, I did want to ask you, because you as far as pro-lifers go, you have perhaps one of the most genuine pro-life stories out of everyone that I know in terms of putting action behind your beliefs. So your son Samuel, tell me about him.
Well, I can't tell you about Samuel without kind of painting this backdrop of what the family he came into. So as of last Friday and a week ago, my husband and I have been married for 34 years. Yes, I got married when I was 20.
Nice.
For real.
Big fan of young
And
marriages.
hey, it worked. He was
Mary was the
26,
same
but I was
age.
20.
Mary
Yeah.
was the same age, my wife.
Yeah. When you're ready, you're ready, And it doesn't mean that it wasn't without bumps and everything else in the beginning, but we have 5 adult children now. And when our number 5 child had just been sent to college, was the middle of COVID, so 2020, and God told us to sell our house in Iowa. It was a 158-year-old historic home. We thought it was our forever home. We were only the second owners. And even in Iowa, they shut down pregnancy centers. And so my client work was drying up. And then I had some for-profit clients that were doing business in Illinois, and Governor Pritzker shut them down. So we just went to the Lord and said, okay, what are we going to do? We've got to pay bills. And the Lord said, sell your house. And we said, oh, okay, well, that'll be a minute. It's the middle of COVID. And And our house is 158 years old, and we're the only, it was on the market 3.5 years before we bought it. So we put it on the market, and the day we listed it, it sold for full price. So we said, okay, good for being obedient, but we didn't have any other clear direction after that other than to move into an RV, to stay mobile, stay flexible, right? When you don't have an answer from God, you have to stay flexible. So we did that, and one of my pregnancy centers at the time said, hey, we're getting ready to try and bring back our nurses. Find me some money. And I said, well, have you heard of the CARES Act? Let's create a registered apprenticeship, a super nurse program recognized by the Department of Labor. And so we created this super nurse program, and under a $250,000 grant in Iowa, rolled it out and trained 9 nurses. We also got a forensic colposcope because these nurses were not only trained in what you would think for a pregnancy center with ultrasound and FEM and sex trafficking awareness and so on, but they were also trained as sexual assault nurse examiners. So we got a forensic colposcope so that women had an alternative to the emergency department if they had been raped, or as most all pregnancy center policies state, that they need to send women to the emergency department for a sexual assault exam if they've been reported sexual assault within the last 120 hours. So moving forward, I was asked to come to Florida and write that same grant under nearly $500,000 under Governor DeSantis's discretionary funds. And in doing that, after just sending our youngest to college, we heard this story about a baby they wouldn't give a heart transplant to without an adoptive family. So evidently his mother she was on Medicaid, generational poverty. She went to her anatomy scan and found out that this baby had right hypoplastic heart and pulmonary atresia, and he had a 22% chance of living. And the doctor said, you should just terminate, get an abortion. But because she was on Medicaid and we still had the HIDE Act protecting Medicaid in the state of Florida, that was not an option for her, praise God. And so her next alternative was to take a Greyhound bus 5 hours from the Panhandle to Gainesville, Florida, which was the closest transplant center, and deliver there where he might have a chance to live. And so this little baby was born at 38 and a half weeks, immediately put on an LVAD, or a Berlin heart, that mechanical heart that beat outside of his body. And by the time I was well into rolling out this grant to 22 pregnancy centers and 34 nurses across the state of Florida, Catholic Charities was in a conversation with me about wanting to upskill their nurses. And I just said, hey, tell me about some of the adoption work you're doing. And the third story was about this baby who needed a heart transplant that they wouldn't give one to without an adoptive family. He'd had 3 massive ischemic strokes at that point, and they were looking for a family. And I said, what's involved in a home study? And they told me, and I went home and told my husband about this baby, and I didn't say anything else. And then a couple days later, my husband was having a procedure done. And he came out of the surgery, and we were driving home, and I said, remember that baby? He says, yeah. And I said, well, what about us? And he immediately, without missing a beat, said, no. And I said, well, why'd you say no so fast? He said, well, I don't want my heart broken. I don't know. You just said they don't know if he's going to live 2 weeks, 2 days, 2 months, or 2 years. And so I thought to myself, okay, I can work with that. He thinks he might get his heart broken, which means he might fall in love with this child. But you cannot go into adopting a medically complex child with one person being all in and the other saying no. You just don't do that. And so I basically did a Gideon's fleece, and I said, okay, then Lord, if you want us to have this baby, you are going to have to burden my husband with this, and he will have to come back to me. And if anybody knows me, they know that the miracle in this entire story is me keeping my mouth shut for 5 days, because that's how long it took for him to come back and say something to me. He came in my office and he had tears in his eyes, and I remember looking at him saying, "What is wrong with you?" And he said, "I don't know. I keep thinking about this baby." And we haven't even met him yet. And the moment he said those words, the phone rang. And it was Geraldine Ryan with Catholic Charities. And she was all bubbly on the other end of the phone. And she said, "Hey, my nurse Nan says you might be interested in this baby." And so
But you're
we
saying that was
went.
right when you were having that
Pardon?
conversation? You're saying that was right when you were having
Yes.
that conversation?
He said the words, "We haven't even met this baby yet." And the phone rings.
This episode is brought to you by Life Advancement Group and our Save More system. I want to talk directly to the pregnancy center directors out there. You're being asked to reach more abortion-minded women, prove your marketing is working, train your team, improve follow-up, increase appointments, lower no-shows, report outcomes to your board, and somehow all of that while your staff is already stretched thin. And then a marketing agency comes along and says, "We can get you more clicks." Well, that's not enough. Life Advancement Group built the Save More system because pregnancy centers don't just need advertising. They need a system that connects the entire process, something that actually saves lives. We do marketing that reaches women who are searching for abortion, training that equips your team for the conversations that follow, technology that keeps every lead, message, appointment, and outcome visible, and reporting that shows what's actually working. The Save More system is built by us, a nonprofit whose mission is rescuing lives from the destruction of abortion. So if your center is ready for more than just another ad agency, go to lifeadvancementgroup.org.
And so I was like, "Oh, I got him on the hook here. Okay." So I said, "We haven't even met him yet," to her, just echoing his sentiment. And she said, "Oh, well, let me call the hospital and see if you can meet him." And within 2 hours, we were at Shan's meeting this little baby that had tubes coming out everywhere. At that point, he had had 4 strokes. They were trying to keep his weight up so that he could get the heart transplant. And he had matched for a heart 4 times before that, but they had turned him down because there was no aftercare, no adoptive family, which is almost unheard of because he was 7 months at that point. And so we're there, tubes everywhere, and they decide in that moment while we're there visiting him that they're gonna put an nasojejunum tube or an NJ tube in him so he could eat. And they give him morphine after, but he was screaming. It was just a scene. And medical stuff doesn't really freak me out, but I thought for sure my husband's be like, "Nope, nope, nope, we're out." And so, um, we get in the elevator after being there about 2.5 hours, and we both lean back and just let out this big sigh. And I said, "So?" And he said, "Well," without missing a beat, "Well, if we're not called to do this, what are we called to do?" I said, "Oh my gosh, are we in?" He says, "Yeah, we're in." I said, "Oh my gosh, God's gonna give us a whole baby." And he said, "Well, he's not gonna give us a half." And I said, "No, no, it's not like that. This is different than just finding out you're pregnant. When you say yes, when you give God your yes, and then he honors that, the just the honor in that whole process and realizing you've been selected to care for this precious child, that God has this immense purpose for the child's life, for your life, the requirement on your marriage, your relationship with God, the demands required in caring for a medically complex child, all of that, that you got tapped, you got picked. God said you. Just in that moment just came rushing over us, me especially. And then it was a very fast process from that point forward. We went through the home study and all the background checks and everything in about 3.5 weeks. We sent 3 bus tickets to his birth mother. She finally took the 3rd one, came and met us. She had left when Samuel was 12 days old and not come back. And so we met her at a Cracker Barrel. We told her about our family. We brought our youngest son at the time, brought pictures of our family, and the only thing she asked us was, "When he dies, will you invite us to the funeral?" And I said, "Oh, well, of course we would, but he's my baby now. He's not dying. God has a plan for this child's life. I just want you to know we're going to care for him very well." And so we left, and the notary and attorney came in, and she terminated parental rights, and we held our breath for 72 hours in case she was going to change her mind for some reason. And we started visiting him at the hospital because from that first time we had met him, we weren't allowed back until the adoptive placement court order was in place after TPR. And so between myself and my 2 sons that were available and in the area, and my husband, we were there at the hospital 5 to 9 hours a day with Samuel. And 2 weeks and 2 days later, he matched for heart a 5th time. He got his heart transplant on June 14th, 2021. And we brought him home from the hospital, first time he ever left since birth, on July 27th, 2021. And the adoption was finalized on December 21st, 2021. And by the way, here's a little side note with all the vaccine controversy going on.
Mm-hmm.
I have a master's in public health and health management and policy, and I knew that I would never have this child vaccinated. I didn't sign any agreements that I would ever have him vaccinated, but Catholic Charities did, because when they started looking for a transplant heart, they had custody of him, so they had to agree to all those things. So when children are transplanted, if they are not vaccinated pre-transplant, then by their 6-month anniversary is when you would be eligible for catching up on vaccines. Well, the day that they decided he would be eligible, that was his follow-up appointment, he was my baby. It was finalized. And I said no. And we had to fight. But I never signed any agreement, and to this day, it is our understanding that he is the only unvaccinated pre- and post live organ transplant child in the nation, and he is
Wow.
very healthy. Bottom line is, God has plans for this child, and he chose him to be in our family with me as his mother and my husband as his father and all of the siblings, and Samuel is thriving.
That is amazing. So you guys, he's 5 now? Is that right?
5.5. Yep, 5.5.
5.5. So my wife and I, we're still in our 20s. I'm pushing 30, but we've got 2 littles at home, 3.5, and going on 2. Can't imagine what it would be like as an empty nester to go back to that life. So you and Borg, your husband, were in your 50s, right? What was
Yep.
that like?
It was hard, especially in the beginning because he was, very complex medically, but also getting up in the night and so on. And yeah, I need my sleep. But it's gotten much easier. And having nurses that we trust here finally has helped incredibly. Uh, my husband had taken early retirement, so he was in a unique position. And because I own my own consulting business, we had just made the agreement in the beginning that he would cover the home stuff and I would be able to travel and do my business. But because I have a home office, there is more flexibility in that as well. Uh, so it just worked out.
Yeah, I can't imagine. Both of you guys are definitely superheroes. To go through all of that, which is the high highs and the low lows, and then just to re-sign up for it again for a special needs child of all, So it's just the normal difficulties that come with parenthood, and then and on top of that, the hospital visits, the trips to the ER,
Well, we
dealing with
keep him
the
healthy. So it's either was in full crisis in 2023 or otherwise he just stays healthy.
That's good.
And because he's immunocompromised, most of the services that he receives, they come to our home. So even now he has an IEP and he's hospital homebound. So his teachers and his therapists all come to our house.
That's convenient.
Mhm.
So you mentioned working from home, but you also travel a lot, right? You
Up
always
until
seem to be
December of
visiting
last year when things changed a little bit for us, but, yes, I was probably traveling every week.
and mainly just visiting the various pregnancy centers that you're working with, or
Yeah, I mean, conferences, probably anybody watching this has seen me at Heartbeat or CareNet and Samaritan Summit or something with Leadership Institute and March for Life, any of those things, and speaking at galas or yeah, doing gap analysis for accreditation, doing board trainings or EOS strategic planning implementation. So they all take me on site.
yeah, I wanted to ask you about that because you said that many clinics are vulnerable right now. I was just curious, what is it that you think makes them so vulnerable?
I would say that mm, pregnancy medical clinics are vulnerable because they carry real medical risk and legal risk. They face public scrutiny, but they are operating with nonprofit habits instead of maybe what I would call medical grade systems. M- Many of these organizations are founded by really faithful, compassionate people who want to help women and families. And they start out with great intentions and volunteers and donated space, a servant's heart, and a real ministry mindset. But once they incorporate and employ their staff and collect records and perform medical services, operate vehicles, run their pregnancy tests in a lab, maybe dispense medications like prenatal vitamins or progesterone. They do ultrasound, so they're providing diagnostic services. So now they're not just ministries, they're regulated corporations. That means that they're accountable to federal law, state law, licensing rules, employment law, privacy law, CLIA laws, and safety and corporate governance requirements and insurance requirements, local building and fire codes, those things. And they're vulnerable because good intentions don't satisfy the regulators and a plaintiff's attorney or a medical licensing board or insurance company. Pregnancy medical clinics are honestly vulnerable most often because they're built by mission-minded people who think like ministries, but the law treats them like corporations and medical operations.
But what do you say, to the organizations? There are some groups out there that are saying that pregnancy centers are not covered entities, so they shouldn't be advertising that they're HIPAA compliant because then it's holding them to a certain level of compliance. Have you heard that?
So, yeah. And so my response is unless they're billing for their services, they're absolutely correct that they're not a HIPAA covered entity required to report any breaches of privacy to uh, HHS, but they can still subscribe to HIPAA standards, and their patient notice of privacy practices just says that they're voluntarily HIPAA compliant. They should have internal grievance processes and um, everything can be aligned and protecting private health information because there's some gray area over transmitting electronically medical information. Even if it's not for the purpose of billing, you should still protect your patient's information and their privacy. So, do I think that they need to be telling them they're a HIPAA covered entity when they're not? Absolutely not. Do they need to say they're voluntarily HIPAA compliant and they subscribe to the highest standards of HIPAA requirements? Absolutely. So
Makes sense.
there's a way to do that and don't fall into the straw man argument.
So hold yourself to the standard, but be clear that you're doing it voluntarily, is what you're saying?
Yes, Absolutely. And so I have created, because I'm a policy girl, notices of patient privacy practices, and policies and procedures for those clinics that are not truly HIPAA covered entities, so they're not billing. But then you run into a state like Virginia, and they have that SB 193 bill that was recently proposed. I think it got pulled back, but um, that was requiring any clinic that offered free services, so they were not a HIPAA covered entity that provided pregnancy related services. That means that the state of Virginia was willing to not only go after pregnancy centers, but their own free medical clinics in their state. And there's 58 of them, of the free medical clinics. They were going to throw them under the bus too, um, and say that they were going to sanction their medical licenses of their medical directors if they were providing pregnancy services as a non-covered entity. And so the only way around that is one thing that I provide, which is to become a HIPAA covered entity, which means you would bill at the very least Medicaid. So you would credential your medical director, and any other physicians or mid-levels with Medicaid in your state. And you're still a free clinic if you do that. You're still a free clinic because Medicaid patients don't pay a premium and they don't pay a copay. And you are a HIPAA covered entity then. You're not leaving money on the table for your poorest patients. And you are still a free clinic. So you meet all of those requirements. And then you have certain organizations in the pro-life movement that say, we never take government money. They're going to tell us what to do. There's strings attached. And my response to them is, well, do you refer to pro-life OBs that accept Medicaid? Well, yes. Do they pray with their patients? Sometimes they do. Oh, look at that. They can still operate taking Medicaid, and it doesn't infringe on their right to pray with their patients.
Tell me more about that, because I've talked to centers that refuse the dollars, and they say that they won't be allowed to pray with their patients or share the gospel. Is that true?
Not when you're talking about Medicaid, Medicare, or private insurance. Absolutely not. Holy Family Catholic Clinic is a great example. They're a multi-specialty primary care clinic located in Oregon, of all places. And they do primary care, pediatrics, family medicine, OB, or GYN, excuse me. They do abortion pill reversal, mental health care, and they have a chapel, and they pray with their patients, and they accept all insurances from county, Trillium, to Medicaid, Medicare, and so on. And I can show you video right now of them praying with an abortion-minded woman who had taken the first pill that came in and agreed to be on video. And it'll make the hair stand up on your arms to see her go through this entire visit with the doctor praying with her and showing her her baby, and being given progesterone. And so, which is a normal practice for treating threatened miscarriage, regardless of the cause. And so, no, I would push back completely. Now, that said, are there state grants and federal grants that say that you cannot pray with your patients when you receive their funds? Sure. Yep. There's many,
But
many.
isn't it? It's not so blanket, right? It's that you can't reimburse for those specific activities. Can't you bill for everything else in that interaction?
100%. That's right. So what they do is say the moment you start praying or sharing the gospel or anything like that, then the billed time that goes towards the grant ends at that moment.
Yeah. So have you ever seen, you've dealt with presumably dozens of state grants at this point with pregnancy centers. Have you ever seen an instance where it was just a blanket, if you receive these funds, you can't pray? Or is it always just, hey, you can bill for the pregnancy test, the ultrasound, go on down the list? Like, give me an example of like your typical appointment all the things you'd bill for, but then how it would work if you wanted to share the gospel.
Yeah. So in this, a great example is state of Florida or Georgia, um, or Tennessee or Iowa. I can list them all. But so they give, they all reimburse for either time or service. And if you find find a patient encounter where instead of following this prescriptive, patient comes in, you do their medical history, their social history, they do the pregnancy test, and then you find out what their LMP is, and they then move to the next area and have their ultrasound, and then you present them with their options, whatever that linear service is. Um, then if they are praying at any point in that, they just don't even worry about charging the grant for the time with that visit. It's too muddied at that point, and it's not worth it when you have an opportunity to authentically share the gospel, or pray with someone, to worry about being reimbursed for that visit, because that's what your donors are there to support, right? That you're not only reaching women in the moment of crisis, but that you're reaching them with something that changes them forever. And so, not just a service in the moment, right? And but there are many, many, like in Florida, where they'll pay by the minute. And so if a visit is an hour and 40 minutes into the visit, you are praying with someone, then that's where the billing stops.
Hmm.
40
What do you,
minutes.
some people say you should be sharing the gospel in every single interaction, every appointment. They operate on if they see 40 clients, all 40 of them, they're sharing the gospel. What do you think about that?
Um, if it is, so I personally believe that who we are as Christians should come naturally out of the conversation and who we are. And you can share encouraging words, um, and if it's a natural progression of the conversation, if they're sharing something very vulnerable and you just, the Holy Spirit should be the barometer and the guide throughout any interaction. Um, yes, we're in a clinical medical operation, and you need to have uh, those guardrails of policy, but they are not made to exclude the Holy Spirit and who we are as people, being Christian and loving people where they're at in the moment. And so we all need to be sensitive to where we're at meeting with women. And if the Holy Spirit says, I don't care what you had to say next or what's in your um, protocol, if this woman needs you to hold her hand and pray with her, then you need to drop everything and do that. Um, do I believe that you need to do it when there's no prompting of the Holy Spirit or it's very awkward and it would actually do more harm in that moment, because you need to check a box or hit a quota? I have a problem with that. And I hope that we're not doing that as an industry. I would hope that our own personal relationship with Christ comes out in our interaction with others, that it becomes natural to share your personal story, your personal testimony, and offer the opportunity to pray with someone
Hmm.
and share what God's done in your own life. And then if they're open, they're open.
Yeah, it definitely seems to be a topic that splits the room. Some people, it definitely does seem, I mean, they literally have a check, like a box to check. They have to check the box. Um, so you could say it's not checking a box, but like in some settings, you're actually checking the box. And especially when your KPIs are tied to that or your end of year update to your donors of how many people you shared the gospel with, there's a pressure on that. Then the other side would say you can't plant, water, and harvest a seed all in one interaction. And so some people you're going to be planting a seed, others you're going to be watering it. And then for some, it's time to harvest. But it's very, at least in my opinion, unlikely, improbable that every single client interaction that you're having you're going to coincidentally be meeting that person right at the time when it's time to harvest that seed that's been planted and lead them to the Lord. Now, the intentions are good, but it's just, I would probably err more on that side too myself, which is be led by the Holy Spirit. I mean, I could get behind doing one of those three activities in every interaction. Uh,
Exactly. And not only that, but what about tying your KPIs to the spiritual development of your staff and the culture and the environment you're fostering inside the clinic? What are you doing for the hour before any patient arrives?
that's a really
Are
good
you
point.
changing the atmosphere in the building so that if it is the first seed that's ever planted for them, or if it is the watering that is needed because you don't know who was in their life 6 months ago that planted a seed, you have to be able to be used as God wants you to be used in that moment. I mean, Christ didn't tell people who he was until he met their need.
Hmm. How would a leader of a pregnancy help organization create that culture amongst their staff? What kind of practices?
I think some of the best examples I have seen that are making room for, well, one, requiring spiritual maturity and development of their staff, two, prioritizing praying together as a group. Three would be then checking in with your team and where they're at in their spiritual growth. Are they working on anything? If you don't provide that framework in your work environment, are you ensuring that they have that in their own church or in their family in their home? Making sure that they're all shored up. Because this is spiritual warfare. And if it's going to happen, it's going to come through the weak point. I mean, Satan's a legalist. So the moment we come into agreement with um, the enemy on anything in our lives, then Satan's going to try to use that as an open door to divide us and destroy us. Honestly, that's what happens.
Mhm. No, it's true. I was going to ask before we moved on from the topic, just on the whole topic of compliance with pregnancy help centers. If your stereotypical pregnancy center was to be audited or attacked or investigated tomorrow, having been through and seen all that you've seen, what would be the most likely thing that they would not be ready for?
Maybe incomplete, not following their own policies and procedures, just getting policies and procedures in a 3-ring binder from an unnamed organization and then putting them in a 3-ring binder up on the cabinet and not following them. Um, what I help organizations do with AAAHC, because this is what surveyors that are helping you achieve accreditation are going to look for is, do you have the right policies and procedures in place, and can you prove that you're following them? So it starts at the top. Do you have governance weaknesses? Do you have a board that's passive, sentimental, or uninformed? That creates risk really fast. If the board is not actively overseeing quality, safety, compliance, credentialing, lining out the scope of the services you're going to offer, evaluating executive performance, then your clinic's exposed. Um, Savannah Martin said a couple of years ago at a conference, it's the one weak link that the other side is going to find, and that is going to make all pregnancy medical clinics look bad. So operating without a medical director would be a big no-no. Having people performing ultrasounds that have not been properly trained and certified. Um, but then there's very simple ones like incomplete policies and inconsistent implementation of them. You might have that binder full of policies, but if you're not actually following them, documenting that you're following them, training to them, updating them as you need to update them, then you're vulnerable. Um, poor documentation is a huge issue. And if you're sued, the first thing your attorneys are going to look for to defend you is, can you document that you have done the right things and you have not done the wrong things that you're accused of? So the one basic principle in medicine is if it's not written down, it didn't happen.
This episode is brought to you by LifeLead, and I should say up front, I helped build it, so take that for what it's worth. I spent years working with pregnancy centers before the software existed, and I kept seeing the same thing happen. They were missing 50% or more of the women who were calling them. Women reaching out, ready to talk, ask questions, book an appointment, and half of them never got a response in that critical decision moment when a life was on the line. Women can get the abortion pill delivered to their mailbox without ever talking to another human being. If a center doesn't get back to her fast, she's not sitting around waiting. She already has another option in front of her. We were so frustrated by this that we created LifeLead. We didn't want to hand centers some generic call tracking tool intended for a secular business. So we collaborated with innovative, high-performing centers all over the US to build this specifically for what centers actually deal with. Every call, every text, every form submission and chat, all your social media message, all landing in one inbox. Something goes out to that person automatically the day or night that she reaches out. It's HIPAA compliant, and your whole team can see every lead's full conversation history in one place instead of piecing it together from 5 different apps. So if you're done losing people because nobody responded fast enough, pause this for 30 seconds, pull up lifeleadapp.org and book a demo. Most centers are fully up and running within a few weeks. Have you seen a lot of that in terms of centers getting sued? By the
Yeah.
state or by
Yeah, so think about it this way. A lot of pregnancy centers don't like to hear that there's another thing that they are being recommended to get, like Teresa Cloud, an FDA 510K compliant viewer. Well, if you have if your medical director or your radiologist is reading a scan from a printed PDF that's uploaded into your EMR, and that's the only thing they're looking in the patient visit that you can prove that they actually opened and looked at, and then they miss an ectopic pregnancy because that one image doesn't show left adnexa to right adnexa, and they're being cross-examined on the stand, and they're being asked, well, how did you know that there was no ectopic that you clearly missed because this patient had a ruptured fallopian tube or died or something like that? Then using a 510K approved viewer means that you can manipulate that image, look at it live in real time on the screen, just as if the sonographer is doing the image for you. You can do light and dark contrast. You can look at blood flow, all those things. And paying $79 a month for Teresa Cloud is a small price to pay to avoid a medical director losing their license and a blemish on the entire pregnancy medical clinic movement.
That's true. One bad example, and it's going to be blown up in the news, and it's going to affect everyone else. So that definitely makes sense. Now, I've heard you push back on the term abortion pill reversal. Why is that?
So, no OBGYN that is mainstream uses abortion pill reversal. They treat serial miscarriage or threatened miscarriage, regardless of the cause, with high-dose progesterone. So treating threatened miscarriage is what they're doing. The ICD-10 code is threatened miscarriage with the use of progesterone.
What's ICD?
So if you're billing insurance, you have to have a diagnosis code and a procedure code. So an ICD-10 code is a diagnosis code. And when you transmit a claim through CMS, the Centers for Medicare and Medicaid Services, to your insurance company, to Medicaid, to Medicare, and they pay on that claim, they have now legitimized that service as medically necessary. You have the proper documentation. It's a standard of care that is recognized. Even if it's off-label use of a medication, it's a standard of care that's recognized. And progesterone has very few downsides to its use as far as low-risk side effects. And the benefits of using high doses of progesterone in someone who has low progesterone, regardless of the cause, especially if it is causing a miscarriage or them not to carry a pregnancy to term, then why not use it? So we use this term abortion pill reversal because it is our pro-life term. But that is potentially promising something that may not be possible in all situations. And so there's a way to advertise to women, hey, did you take the first pill and change your mind? There may be an answer. Get a medical exam, get an ultrasound. Let's see if you're still pregnant. There's still a heartbeat. Is it been less than 72 hours? We may be able to give you a medication that can help. There are over 8,000 babies saved in the US from using high dose progesterone after someone has taken mifepristone. So we know it works. But why feed into the attacks from the left when that's not what mainstream doctors are doing?
Yeah, I mean, I guess my only pushback on that would be that the terminology for me, what's going to be most important it's really not for me. It's for the client. It's for the person who took the pill. We want the language to be as clear as possible so that they know what they're getting. And for someone less educated, they might not understand that, if you're talking about a miscarriage risk reduction, is that what you said?
Say
Miscarriage
that again?
risk reduction? You're talking about instead of describing it
Treatment
as a
for treatment for threatened miscarriage.
threat, yes, treatment for threatened miscarriage. So they might say, I'm not threatened by miscarriage. I'm threatened by abortion. I took the abortion pill. They might not understand the distinction. It's the same thing. It's causing miscarriage. We know that, but do they know that? And so,
How
coming from the
about did you
marketing
take the
background,
first pill and change your mind?
yeah, I like reversal. I like the term because, yeah, it's not guaranteed every time, but it's essentially going to reverse the action of the abortion pill. And so it's kind of like the dumbed down version of it. You're not
Yeah, we
saying,
just have to be careful about making claims that
mm,
we can't back up all the time, because that's where we can become vulnerable to, legal issues.
so if it was you, how would you advertise it? What would you rename the regiment for a consumer friendly name, right? So you're advertising this to abortion minded women who took the abortion pill. What's a consumer friendly name uh instead of abortion pill reversal to advertise a high dose of progesterone?
So, I think that the best way would just to use language like, "Took the first abortion pill and changed your mind? You may still have options. Uh, you can speak with a licensed clinician now. Urgent ultrasound and evaluation is available." Um, I just wouldn't market it as guaranteed reversal. I would market as urgent, time-sensitive medical evaluation for women who took mifepristone.
These all seem
Um,
like ad copy and um like disclaimers, not necessarily objections with the term. So are you okay with the term if it's paired with these disclaimers and this ad copy that goes with it to describe it? Or would you
you
rename
could
the
just
term
say
altogether?
post-mifepristone continuation care or
Yeah,
threatened
but I'm an
miscarriage.
abortion minded woman and I say mifepri what? Say I took the missed period pills. What are you talking about? I took Plan C. I took the
Take the
abortion pill.
first pill and change your mind? I mean, honestly, that's what I would say.
Yeah. We'll have to we'll have to
You
wordsmith
may
that
still have
together.
options.
I mean, I love naming things. I just love the simplicity of the reversal. I love the simplicity of the term. We'll have to dial that in because I hear the side that you're making. It's just you have to come up with a succinct term that's
I
still going
mean,
to
it's
work from a
miscarriage
marketing standpoint.
mitigation.
Yeah,
Um, it in mainstream medicine is recognized as obstetric care for threatened miscarriage.
in mainstream medicine to a doctor, right, or to someone with a medical background,
Mhm.
but to the average client, I don't think they're going to understand that. And if you miss on the messaging, it's you're going to miss on you're going to miss out on reversals, right? I want to
Yeah,
communicate it
but
in a
look
way
at the
that's gonna
clinics
in the
that are
most
being sued in
clear.
California, right, for
Okay.
using abortion pill reversal.
Yeah. No, that's
So
true. But I mean, what's the response to that? It's like, I guess it comes down to, do we change our strategy, change the name because we're getting sued, or do we push back on that? You know, um, at the end of the day, you're right. I mean, it's not
either that or
the
somebody with
product
some
itself
big
is
money.
progesterone,
Somebody
and
with big money needs to fund a peer-reviewed NIH study on this with a large um, N study group and make it mainstream, make it standard of care with that term, abortion pill reversal. The thing that I don't like is when you look at, say, like cancer care. There are clinical trials that have turned into FDA approved drugs that um, you can take this pill that can address a mutation in a cancer cell. And for 1/3 of those patients, it'll shrink the cancer growth. And 1/3 of the patients, it stops the cancer from growing further. And 1/3, it does nothing. So there's no guarantee other than this is the treatment that may work for you.
I mean, that's fair. I mean, we know what's the efficacy rate right now, like in the 60s.
67%, I think. I think.
It's pretty good. It's
Oh,
pretty
it's
good.
excellent.
But we don't put that same burden on other medications to say, like, you're still advertising it does this, right? And then you gotta have those disclaimers for sure.
Yeah.
Um,
We'll have the fast talking guy at the end.
yeah, may cause sudden death.
May cause nausea,
Yeah,
vomiting,
well, that's the
bloating,
beauty of progesterone is the side
fatigue.
effects are very minimal, right?
Manageable. Yes, yes.
Manageable is a better term.
Yeah.
I mean, they're inconvenient, at times, but they're not life-threatening as far as I am aware. It's cramping, it's mood. Um, there's some other things in there
Ultimately,
like
though, this still goes back to the original question you asked and what's gonna get pregnancy centers in trouble. And using precise clinical language really does matter. It keeps the focus on the patient's condition, having informed consent, using medical judgment, um, documenting things, using recognized coding practices rather than a politically loaded phrase.
I think it's fair. So, I asked you, before we were filming and all that, I asked you what's a topic that we're perhaps avoiding in the movement, or rather something that pro-life leaders would really need to hear if you
Mhm.
had an audience with them, which you do right now.
Yeah.
And you you had talked about this theory of pillars and how
Durability. Durability.
durability, but
Mhm.
durability to political change, right? And how like
Yes.
everything changes with each new president, and how do we become more durable through that? And you talked
Mhm.
through this theory of pillars. And I never heard that. That was really interesting to me. You said there were 6 different pillars that we need to focus on. Can you tell me more about that?
Yeah. So I really do believe we're avoiding this conversation about durability. And too much of the movement still operates as if one election win or one court victory, one great governor, or one favorable administration is enough. And we all know it's not. Dobbs returned abortion regulation to the elected representatives and the states. But the years since have also shown that how quickly federal guidance, enforcement posture rather of certain states in particular, um, how they interpret funding, all those things can swing with political groups. Um, I mean, HHS rescinded prior EMTALA abortion guidance in 2025. Title 10 rules were rewritten in 2021. The Department of Justice built a reproductive rights task force after Dobbs, and in 2025, the federal interpretation of Hyde shifted again on abortion-related support services. And that's really exactly why our movement can't be built on politics alone. It has to be built to survive political regime changes. And the conversation that we're avoiding is this. Are we building a cause or are we building durable institutions? If we want to survive the roller coaster of support and attacks that come with political change, then we have to stop thinking in single lane terms. We need a full ecosystem, and we need to be bulletproof and legally defensible. We need our medical clinics, our advocacy organizations, our education leaders, lawmakers or litigators, the funders, and culture shapers. We need all of them to start operating like that with laser focus on mission. And
And those are the pillars you're talking
yes,
about.
so we position our movement collectively to survive political regime changes with the 6 pillars of law and policy, legal and judicial, regulatory, medical, and agency, services and funding, education and parents, culture, media, and messengers, those influencers. And so inside each of those 6 pillars, you have operators, the people doing the work every day, validators, the people who give legitimacy and credibility to that work. You have defenders, the people who provide legal and reputational and political cover. You have funders and enablers, the people who provide the capital, the access, the infrastructure. You have messengers. They are the trusted voices who can move specific audiences. And so inside law and policy, you would see those bill drafters, state coalition leaders, policy directors, legislative staff, grassroots mobilizers. Those are those operators I was talking about. And you would also see physicians, economists, disability advocates, child welfare experts, and researchers. Those people validate the operators. You've got your constitutional lawyers, your allied attorneys general, policy communication teams, and legislative counsel. Those are the defenders under law and policy. You have in your funders and enablers, you would see family foundations, donor networks, advocacy groups, church networks, the state policy partners. And then the people that are the messengers under law and policy, you've got lawmakers, governors, state agency allies, moms that have been served by the clinics, those stories that have to be told. And then, of course, groups like APLOG, pro-life physicians, Catholic medical associations. Then if I can tell you who all these are under legal and judicial and regulatory, medical, and agency, and what it looks like under services and funding. Since we are probably talking to a lot of pregnancy medical clinic leaders here, under services and funding, you're going to see in that operator group, the clinic leaders, the executive directors, the development staff, the grant writers, the case managers, the volunteer managers. Those are the operators. And the people that validate their work, those are audited outcomes, accrediting bodies like AAAHC, strong governing boards, community partners, patient satisfaction data. So they're doing quality studies. They're getting their patient feedback and they're compiling it. And the people that defend that work, those are the finance committees, the governance councils, the HR support, donor relations professionals, crisis management teams. The funders of the services are monthly donors, major givers, family foundations, church partners. So it continues to flow down. The people that get the message out of the services and funding, those are the clients and patients you've helped. It's your executive directors, the faces of your organization, your board chairs, your donor champions, of course, your medical directors and physicians, and really important are the local pastors of all the churches in your community.
I would agree with you there. There's 6 different pillars you're talking about. Why do you think that the first pillar of the pro-life movement, not in order of importance, meaning you've numbered these pillars, but it's not sequential. It's just there's 6. And the political pillar, the political arm of the pro-life movement seems to get so much focus and attention and funding. Why is that when there's all these other areas that are necessary and important?
You know,
What's your, I mean, what would you speculate?
my knee-jerk gut is follow the money. It's always follow the money. And politicians want to get reelected. They need donors, they need voters, right? And so when it's politically expedient, all of a sudden they champion the pro-life cause. And when they don't think it will affect their ability to be reelected, then they stop thinking about what's important to the voters. And I would say a very large portion of the pro-life community, they vote with that being their leading issue. They first look at their political candidate's pro-life stance. Then they look at other things, where are they on marriage and family? Where are they on finance? Where are they, on parental rights and so on and so forth, right? But the pro-life issue really tells you where they're at spiritually, constitutionally, and if they align with you at a very, very core level. And so the money follows the political candidates. And we know that we can't do any of the work we do at the service level without funders. We can't change messaging without paying for marketing. We can't sustain a movement over political changes over a long period of time, 50 years, without money. And so if you can't fund campaigns, then that's where the pushback politically comes.
Yeah, it just seems that there's so much money and attention going towards political lobbying and the pro-life movement, which is so necessary, but also one, it's the long game. Two, it's basically useless if you're not changing hearts and minds on top of that.
And the real question isn't really whether we have the right people in the movement. The real question is whether we've named people to champion each of those pillars and in those roles. And we have to have enough overlap in all those areas with people championing what they're good at, what God has called them to survive the pressure. I mean, that's where movements become resilient, not when they have passion alone, uh, but they have depth, they have bench strength, they have legal cover, medical credibility, funding diversity, and ultimately, trusted messengers who can carry the mission through changing administrations. The pro-life movement will not survive on outrage, optimism, or election cycles alone. It will survive if we build a full spectrum infrastructure across those 6 pillars with the operators and validators and defenders and funders and messengers needed to hold the line no matter who's in power.
Couldn't have said it better myself. It's the perfect ending point. Shawn, for people listening who work at a pregnancy help organization, what would their next step be if they wanted to get involved with you?
Email me. Go to my website,
What's your website?
www.zierkeconsulting.com, or email me at Shawn@zierkeconsulting.com. And I would love to chat with you, whether you want to form a state coalition. I've done 8 of them so far. 501c6 that withstands political climate. Maybe you're interested in group buying. You need to shore up your board. You really want to withstand the time and the pressure, and you really want an ironclad organization. Let's start at the top. Let's get your board in order. Or if you want to be accredited, you want the right policies and procedures in place, you want to pursue HHC accreditation, so that you know that a third party has validated how you operate, that you have the credentialed practitioners, you have the right policies and procedures, you're pursuing patient quality and patient safety, I would be happy to talk to you.
And I can vouch for that too, having been a recipient of some of those services. Very pleased, very happy. Thanks for
You're
coming
very
on the
welcome.
show. We'll
You're
have you on
welcome.
again.
You got me.
I'm looking forward to the
Awesome.
next time. Good to see you,
See you
Shawn.
soon. All right.